but also thank you for the opportunity to speak today. Just bear with me for a second. I'll share my screen and get the presentation going. I'm going to try and keep it relatively short so we have lots of time for Q&A, upwards of 300 participants here. So I want to have you guys have a chance to ask some questions and some fun stuff in the middle that I'll share in a bit. So a brief outline, like it's been broken up, and I think we've all talked to death about this through various newspaper articles and such, the first wave and second wave. So the first wave, we'll talk about some of the challenges we were presented with, how we dealt with those, what the realities were after we kind of went through it, or we're going through it. And certainly the reality, the expected reality and the lived reality was very different in terms of how we experienced this. And then the learnings we have from the first wave that we've now used as we move into our second wave. And second wave, I put expectations. We talk a lot about we've hit the second wave. I think community-wise, we're starting to see the second wave. Certainly in the hospital, we haven't seen that yet, that second wave pushing. But as we all know, we've all become experts on this, where we know the community spread leads to hospital spread 2 weeks down the line. So we're anticipating that coming. And then some of the innovations that we've looked at St. Joe's. I mean, obviously a very biased person here, but I love working at St. Joe's. They're a very innovative hospital, innovative group that's willing to look at things and try things. And so we've had a couple of innovative projects that we'll talk about in an effort to offset some of the challenges we see. So what we won't be doing is things like this. So I think that we've all become in tune. So those who haven't gone there, worldometer.info gives you a great outline of current cases for the day, new cases, new deaths. You can graph it. You can just go down the rabbit hole and spend hours on that site. And certainly that was my experience. I think a lot of our experience in January, February, and early March, listening to the national and what's happening today. And finally, for our mental health, we're like, we need to step back from here a bit and kind of live a little and try not to be so saturated with the information as it was coming out on social media and et cetera. And we won't be sort of digging into some of the epidemiology, because I joke and we always say we've all become armchair epidemiologists. And I think we all experience this, that whether you're out for coffee or dinner or with friends, or you're on social media, and just everyone now has got an opinion and an expert. And no, you don't know what you're talking about. I know what we're talking about. And so we won't spend a lot of time on the trends and epidemiology stuff and focus more on kind of what's happening. Having said that, I thought I would give a shout out to a few of my colleagues that are actually quite valuable to if you're on Twitter, on social media, and trying to kind of weed your way through what is noise and what is value. Dr. Kwan, Dr. Fissman, and then the last three are infectious disease specialists. The first two are more epidemiology. Dr. Kwan does a great daily update of new cases, new deaths, trends. It graphs it for you beautifully, and so it's a nice resource to check into to see how things are trending. And it really isn't. She never does anything from a speculative or sort of personal opinion. It is very factual and very down to the bare bones, and so it's quite helpful. And then at D. Fissman has a great way of breaking down what you're seeing in the epidemiology and what to expect. So he does a little bit more speculation, but it's kind of learned speculation and educated speculation. And then the last three, the middle one there at Zed Chagla is Dr. Chagla, our infectious disease specialist, who I joke has become like a media darling. So infectious disease used to work in the background and you wouldn't see them very often, and certainly wouldn't see them on TV, or rarely would see them on TV. And now these guys have become like the Kardashians. They're just everywhere. And so it's quite funny seeing out there. And so they are actually amazing clinicians and again, very insightful on local things. And so Zed Chagla is the Hamilton one. The other two are Toronto. And so he's worth a follow because he will talk about the local impact that's happening. That's harder to find sometime certainly on the national media. The Spectator tries to get it out and gives us a regional view. And certainly the regional view is one that we have been a pocket of escaping some of the chaos that's happening in the Peel, Toronto, Ottawa region, and have managed, and there's been lots of speculation on why that is, but certainly in the first wave, and again, we're seeing early in the second wave, Spinco notwithstanding, that it isn't seeing a large community spread. And there's sort of lots of speculative reasons, but no one's really certain why that's occurring, and not certain that that's going to persist is the other problem as we sort of prepare moving forward. The other thing that's changed for a lot of us, obviously this Zoom and all the other applications that are here. So in some that aren't here, my life has become this almost every day, sitting with these various roles, sitting in front of a computer screen and talking. And it's, in March when it started, it was like, this is amazing. Look how efficient we are. I can have lunch and be back on a call, and I'm not driving somewhere or driving back and forth from somewhere, and my carbon footprint. And then you realize, and I'm sure all of you have experienced it in your working careers, that a lot of the work that you get done gets done in that 5 minutes before the meeting starts. And so some of this is really lost in the technology. You get on, you have your conversation, and you solve the problems, but you don't have that side conversation with, oh, Mr. Smith, while you're here, I wanted to talk to you about X. And so that's been a struggle to try and figure that out. And just the sort of the mental health of being teed up with a phone the entire time, and with the TV the entire time. And so the other ones that aren't here is we use WhatsApp and Slack, and those are two communication pieces that we've brought up for our group, and many emerge groups are doing it as well. And it's a great resource to share resources, to share ideas. It does experience in the first one, it can escalate anxiety very quickly. So there was a lot of anxiety on WhatsApp as we were going through the first wave, as people weren't sure what was going to happen and what was going to happen next. And so it led to articles about, here's what's happening in Italy, here's what's happening in New York, here's what's happening in Washington, those first hot spots. And some of it was extraordinarily anxiety provoking, and hearing about lack of resources, hearing about no ventilators, hearing about no beds, and just waiting for it to happen to us. And everybody, I'm sure, is familiar with this. So flattening the curve, that's what we heard over and over and over again in the first wave. Interestingly, haven't heard it as much in the fall, but certainly this was the mantra in the spring, right? We need to, here's our resources. That dotted line represents the resources we have in our healthcare system. If we don't flatten this curve, we're going to overwhelm our beds. We're going to overwhelm our ventilators. And to the credit of all of us, this is what happened. So this was our lived experience in Emerge, which was empty waiting rooms and drops in volumes. And again, I think really partially for Hamilton, it was a lack of community spread, but I think a credit to, and there's not enough said about this. There's so often politicians get up in the front and make us feel guilty for seeing your loved one on Thanksgiving or expecting to have Halloween, but there isn't enough, I think, sort of in it. I think, again, this is where the communication piece is enough congratulations to the public, because it really was all of us, all of you, everyone that buckled down and that sacrificed and led to what was about a 40% reduction in our emerge visits between March and May. And once we got into June, we started to see a return. But it was interesting because my life between February and middle of March, April was really spent on guidelines and protocols and what are we going to do next. And what we found was this. And so then I had to pivot and drop shifts. So we had two physicians, one physician so St. Joe's has the urgent care in King Street and St. Stony Creek, and then the Charlton site. And so we dropped a shift at each site because there just wasn't enough work for us to do. So, and I remember obviously getting a ton of media requests. And so I think it was CBC Hamilton reached out and wanted to have a conversation about it and was really trying to sort of pump up the chaos of it and pump up how we're fighting a war. And it almost felt disingenuous because yes, we were totally different in how we went to work, and we put on our gloves, and we had a surgical cap that we never used to wear, and we wore a mask all the time and goggles to protect our eyes. And then when we left, I would take all that off. I would go home and I would leave that all in the garage, and there was all that piece of it and anxiety. Could you bring it home? And we weren't entirely sure how it was transmitted, and so there was anxiety about it for sure. But it felt disingenuous, and I felt sort of like the imposter syndrome of people saying, and people were so generous to say, we're so thankful for what you guys are doing. And our lived experience in Emerge, beyond just that anxiety of perhaps getting it, was that it was one of the easier times to be an Emerge doc because there just wasn't that many people in the hospital. And when people did get admitted, they could potentially quickly go upstairs because we were sitting at 50 to 60% capacity in our hospital overall, with a 30-40% reduction in emerge visits. And so we actually, at times, you could shoot a cannon through our hospital in preparation for ultimately what never came. And so that's some of the experience that we've got, and we'll talk a bit more about how that informs what we're doing now in the fall. But as we speak to anxiety, so this was probably the number one anxiety we had. So for those who aren't familiar, those are N95 masks. Ironically, 8210 is my size, so everyone gets fitted. And so it's when you see people out in the communities with an N95, I always have a little chuckle to myself because the purpose and how those work is to be properly fitted. There's about 5 or 6 different sizes, and you need to go through a whole fit test to make them actually work properly. And so I appreciate that people are anxious and they'll take whatever they can get. And And most people feel like, or are told really in the public eye, that an N95 is better than a surgical mask. And when we go in to do a particular procedure that's high risk, we put an N95 on. So it stands to reason that the public would want an N95. It's sort of a natural thought process, but likely isn't affording you that much safety. But this was one of the first times where we had a crisis in our emerge. Was how quickly we came. So we had so PPE, or personal protective equipment, is what we use, the generic term for everything that we need. And we had a lot in October, November, December in our stores as we were thinking about this, and it was depleted very quickly. It was depleted, unfortunately, through anxiety for the most part. So overuse in situations we didn't need it, and hoarding by people who would take it and take it home so they would have it. And so we depleted our supplies very quickly. And I remember sitting in a meeting in early March, and the chief of staff talking about how close we were to out of our stores and looking at other options, and none of those options being particularly palatable to an emerge doc who was going in and putting their life in risk. And so we went to this. And so, as I talked about anxieties on WhatsApp, so started to look at other options. And so all of us ran out and bought these 3M elastomere masks that provide sort of the N95 protection, but couldn't get them through emerge, couldn't get them through the hospital. They had N95s, so we were looking at other options. And so we were at the point where we're not going in to do a particular procedure that's high risk if we don't have better protection. And so there was one Tuesday afternoon where one of our emerge docs drove down to Niagara Falls because WhatsApp popped up. They had a big supply of a Canadian Tire in Niagara Falls. So down he went and bought us all supplies. And that was sort of that moment of is this going to work, and what are we going to do, and what if someone comes in really unwell into the emerge, and I can't, I mean, obviously as the chief you feel personally responsible, I can't provide them with the equipment they need to care for them. And so it would become a physician's option of, are you going to overlook this and just sorry, just seeing what the Q&A question was there. Oh, perfect. Okay, so I thought maybe my talk was getting jarbled. So are you going to overlook this and still save this patient, or are you going to protect yourself, which puts the provider in a horrible position? Fortunately, and this was over the course of like a 24 to 36 hour period, we secured some supplies, and really what we call our burn rate, or the amount of use of it, went way down because of all these things stopping. We stopped PORs, we stopped patients coming through. We became a little more adept at recognizing where are the issues and where aren't the issues, and when do we need N95s and when do we don't. And so it started to get better. And now we've kind of waxed and waned through periods of time where we are short on hand sanitizer and short on gloves. And I just was on one of our business people at Joe's. We were on a meeting the other day, and he said gloves used to go for 8 cents a unit, and now they go for 24 cents a unit. And every similar PPE is similarly gone up. And so someone asked on the call, I said, well, didn't Rob Ford come out and say that, well, we're not going to allow price gouging? But the reality is, I think we all knew that for a political ploy, but not really any emphasis behind it. And so we're still seeing that, unfortunately, and the challenges of coming from various areas and getting the supply in. And anyone who's ordered furniture or ordered some supply know that the supply lines and the time to get things have gone way up. And so we're feeling that in the hospitals as well. And people were starting to say, like, is this what we're going to get to, and what sort of internal things are we going to have to do to start to get better? And so thankfully it never got to this, although in the US you never know what they do down there. So which led us to talk a bit about healthcare transmission rate and outbreaks and things. And so there was lots of discussion around this, lots of studies sort of post hoc after the first wave, some of it coming from Europe, nothing really from China. There's been very little accurate data coming out of there, but a lot of the experiences in Spain and Italy and the UK have driven some of our information. And so what we actually found, and we experienced this in the hospital too, is the public is very good at getting information from the spec about, oh, there's been a positive healthcare worker at St. Joe's or somewhere else. And so I think I think that's important. I think the public should know that. And what's interesting when you break it down is a lot of it was happening in social settings. So you go to a break room, you take your mask off, you'd share food, you would have a conversation. And so as we contact traced in the hospital, which we're still doing and are a bit more effective and nimble with it than necessarily in the public eye, you'd see that actually it traces back to a social setting. And so when we're in our masks, when we're in front of patients, the risk is very low, except when you run out of stock. And so some of the experiences we saw in New York, for instance, was healthcare workers getting sick and dying, but also stories of people showing up in garbage bags because they were out of fluid-resistant gowns. And so, if provided with the appropriate articles of clothing, risk is actually extraordinarily low to us. In fact, we tell people when we're talking about our risk as we get together with other people in the summer when they opened up the bubbles a bit, that a forward-facing clerk was actually, I would argue, at a greater risk at times than us. Obviously, we're at a greater risk of encountering someone who has COVID, but we're so good now at isolating them and really protecting ourselves. It's amazing how cavalier I used to be for a fever and febrile illness and cough and URIs that we'd see, that I would not really protect myself as much. And now we're unbelievably protected, and so actually are quite safe, or we feel we're safe in the hospital. We're just convincing ourselves of that. But the data would suggest that support that. And so this is some of the things that people would do. And so this is a nurse in the UK who didn't want to have her clothes on because she didn't want to have to worry about it. So she's wearing a bikini, and over that bikini, she's got PPE and varying degrees of different choices of PPE. And we still see that with goggles. People wear full swim goggles. People have their own little choices of what they like and how they like to do it, and how they like to don and doff, we call it, which means putting on and taking off. And so, yeah, so you'll see some crazy outfits in there. And the clothing thing has become less of an issue. We've become more aware that perhaps the virus doesn't stay on surfaces as long as we thought it did. And so we're a bit more protected from that perspective, and probably a little bit of just fatigue, frankly, where you can't just continually take your shoes off, wipe them down, put everything in a bag. And so people have become a little bit lax on it, but we haven't seen a concomitant increase in healthcare transmission. So first wave and what we learned and what we had to do and what we had to think about. So the first thing I had to think about was, okay, so not everything else is going to stop. And in fact, one of our great anxieties we learned as we went through was that the rate of people coming in with heart attacks and strokes dropped by 10 or 15%. And so we think, well, are people just less active? Are they doing less and therefore not triggering these illnesses? Or are they staying home out of fear? And I think there was probably a little bit of both, but probably more the latter, more the fear, because we were seeing people coming into hospital who were a bit further along in their illness, a little bit more sick than they would have in non-COVID times. And so my challenge was, how do we separate those two? We're telling the public it's very safe to come to hospital. How do we make that happen so you're not sitting in the waiting room next to someone who has COVID when you're coming with an ankle sprain? And so figuring out plans to separate those two people, and do it when initially we thought we would have the same volumes of individuals coming through. And we run a very efficient emerge that's the highest volume emerge in the city. And so if we had to encounter the same emerge visits with the overlay of COVID, or an increase in visits with an overlay of COVID, how are we going to move people through? How are we going to protect people? How can we look people in the face and say we're actually doing that? And so many of the first meetings were about, okay, let's think about how we're going to do this. Let's think about how we're going to separate people and what we can do. Unfortunately, we had some leftover space in places. One of the sort of secrets of the hospital is there's actually lots of physical space in the hospital. The government just doesn't pay for enough staff to staff it. So we did have some flex in areas that we could go to. And we're fortunate enough that we were actually in the process of doing a renovation to our psychiatric department, but hadn't yet started. And so had a space where previously fracture clinic was, so we could move patients through there, sequester potential COVIDs, see them first. Once we're comfortable that there wasn't a COVID illness, we could sort of then move them around. But as anybody who's been in a contemporary emerge knows, there's no magical separation here. People are walking around, somebody's coughing, that's going to spread. And so really took that to heart. And then the next step after that was, what if you get admitted to the floor, and how do we prevent cross-contamination of people with COVID, people without? So developing a COVID unit on the floor, that when we admitted people who were positive for COVID could go to that unit. And of course, as it turns out, our hospitalization rate peaked at, I think the most we ever had in the hospital were 11 or 12. And so we had, again, units upstairs available for that. And so the interesting thing that came out of those two things was that we actually struggled, despite our volumes, getting people upstairs, because what they enacted was, we're only taking people into the COVID unit if they're COVID positive, and they have to wait to get their swab returned. And that leads me to the lab turnaround time. And so the lab turnaround time was got extraordinarily slow, like upwards of, and I say that now, and that would be glory times right now based on what we've experienced, but 18, 20 hours. And so people who would be admitted would stay and emerge, even though there was a bed, because we were waiting to see if they were COVID positive to go upstairs. And one of my very first memory, and forever will be my very first memory of COVID, is sitting in a meeting, or about to go into a meeting, still in person at that point, with Dr. Smea, who's runs the lab in Hamilton, and said, Greg, we're in trouble. And we're in trouble because we're going to have to test all these people. It's coming to our shores if it's not here already. And most of the utilization and the tools that we have for that comes from Northern Italy. And for those of you who remember, I'll say remember history, but it's only been like 9 months ago, the outbreak was in Northern Italy. And he said, so we're going to not have our reagents very soon. And so he was very quick. And I think we saw that in some of the news reports about why we were a bit quicker around the Hamilton area, because he quickly realized they needed to come up with another reagent. They needed to think about robots and other innovative ways to get our labs done, because we weren't going to get it from Northern Italy. And that was exactly the experience. And so that was like January the 14th. I remember sitting there and thinking, I came home to my wife and said, we're in trouble. And Merrick was like, we're in trouble. And so that was our first experience of it, and learned from that moving onwards. And then, of course, the other piece as we evolved was the long-term care. And one of my colleagues described, and it's awful to say, but I think in the end will be true, that the long-term care is our Katrina. And I remember that sticking with me, and thinking at the time, yeah, maybe that seems a bit hyperbolic. And then our experience in that first wave was exactly that what people had to go through in the long-term care, not only those that were positive, unfortunately, even positive, obviously passed away, but positive and had to live through it, weren't positive, but were completely sequestered in their homes. And then being privy to some of the on-call calls we had about some of the homes in crisis, and hearing about the lived experience in there. We've been derelict to that population for many years from a cost perspective and from an oversight perspective, and I think we're now paying the piper. And so there are maybe some things that will come out of there are definitely some things that have come out of this that have been positive, and not that this is a positive thing, but shedding light on our sort of our disregard for long-term care oversight, hopefully is one of them. And then the last challenge that arrived was an AGMP. So an AGMP, if you had asked me exactly a year ago, I would have not necessarily had that in the top of my mind. But AGMP stands for Aerosolized Generating Medical Procedure. And so they quickly determined that COVID was more of what they said, aerosolized, meaning in the air, as opposed to necessarily just touching something or coming in contact with things. That was more likely to be transmitted by the air. And so then that became a problem, because we needed to identify those procedures that were more at risk of generating that aerosolized thing. So what is it? AGMP is aerosolized generating medical procedure. And then what qualifies, and what do we need to change? And then again, this concept of burn rate came up. So if we over-identify AGMPs, that means more N95s, because that's our highest risk procedure. And so what's that going to look like in terms of our stores, given that we're running this thin edge of possible stores available? And so we then had to revamp a lot of our code blues. And so code blues are when patients come into arrest. And so we had to then consider that each one of those was potentially COVID, even though we didn't know, obviously, and no one could give us background information. And so that meant putting on all of this PPE stuff. It meant 1 or 2 or 3 people in the room at the most, as opposed to 5 or 6 or 7. So we had to run simulations on how that would look. How do we communicate? There was one of our colleagues put out on Twitter and had an unbelievable community response, needing baby monitors at the time, so we could communicate to people inside, because we couldn't open and close the door. We had to keep it closed. And so really sort of had to revamp how we approach what is already a stressful and most sort of critical time for us in Emerge. And then it evolved from there to say, well, is CPR really generating an aerosolized because the patient's not breathing? And then there were studies on that. And do you need it? And if you come into a room and realize your patient is arrested, then what? Do you leave and put stuff on? Do you start CPR? Because we know early CPR is the best thing we can do to get people back alive. And so it just added another overlay of wrinkle to everything that we had to do. And so that was our next step after we developed our flow of how we were flowing things through, we then had to talk about, okay, how are we going to treat these patients? So if someone comes in with a cough, we can just put on our PPE and see them, no problem. But if someone comes in with a cough and breathing at 40 respirations a minute and his oxygen or her oxygen levels are very low, that's a very different experience. And what can we do? And a lot of the things that we would give people to prevent them from getting worse potentially made COVID worse, and potentially made the risk to everyone else for COVID worse. And so how do we reconcile that? And who gets a ventilator and who doesn't? And having those tough conversations from an ethical and moral point of view with our critical care colleagues of, are we going to get to a stage? And there was a stage progression of who would qualify for a ventilator if we got to the point where the ventilators were available, or there was only a select few. There was a clear-cut criteria for, we've got one ventilator left, we've got 2 people who needs it, how are we going to decide? And there was actually a very clear outline of how that would come. Fortunately for all of us, that never got to that, because I can't imagine the impact that would have on the family, the impact that would have on the provider, to make that call. That's just not how we were trained and how we ever expected to have to do. So some really scary progressions of where it could have got to. The lived reality wasn't as bad. As we've evolved, we've tweaked what qualifies as an AGMP a little bit, and also tweaked how we do it, because we're really trying to keep track of our PPE, in particular our N95s, and so trying to make sure that we use it when we need it. But if it truly isn't an AGMP, then don't use an N95. Use a regular surgical mask, because we have lots of those around. And so that was challenge. And so this was what would be in front of every one of our doors. This is actually an HHS picture that we use across the city, and essentially would say, if you're going in to do an AGMP, the first ones of those, all those things we would normally do, wash your hands, put on a gown, put on your mask and goggles and gloves. But then it would also be, so that's all the droplet precautions. And then the other thing would be the N95 respirator. And so those would be placed in front of a room to remind people not to just open the door, because the other thing they would have to do is all these things would have to occur in a negative pressure room, meaning sucking that bad air out with a filter instead of pushing it into the public domain and into the rest of the emerge. A few of our docs sort of took it upon themselves to look at other options. So this was for intubating someone, which really in emerge is probably our far and away our most common procedure that we do, that would be an AGMP. And this was a little box with 2 holes that you could put your hands into. And the theory was, if they're aerosolizing within that box. And there was other things that we'd add drapes over top and a few other things. And all of these intubations would have to be done by video. So that gentleman is holding a laryngoscope that has a video on the end of it, so we can look up at the screen and see the cords and pass the tube through the cords. Because if you get right down like we normally intubate, you're then breathing in all of that bad air. And so we actually elected not to use this. In part, the studies that we found that we did just internally, our internal studies with different air solutions and different lights to see where the droplets would go. We found that, again, and you're trying to think of everybody in the room, it protected us, but then we removed that box and we just unleashed these droplets to the respiratory therapist who was with us, to the nurse who was helping us, to everybody else in the room. And so it just felt extraordinarily icky, is probably not the professional word, but professionally inappropriate to protect ourselves at the risk of everybody else. And so elected not to do it, and do it more with our N95s and the video, to stay away from the mask and just make sure we're all protected as best we can. The new studies, again, Zane Chagla, the one I mentioned on social media, is sort of starting to be a proponent of maybe the N95 is even too aggressive, that actually with a surgical mask and protection and a shield, you probably would be okay anyway. And again, the studies are showing that we're not really getting COVID from those situations, that when they trace them back, there either was a lack of PPE or it was done in a different area and wasn't part of the aerosolized generating procedure. So it was really a concern that wasn't there. So that was our first wave. And so we get a bit of a summer break, and everybody sort of relaxes a bit. Everyone gets to go outside. For me, and it was mentioned at the start about our hard luck team, so I entered the bubble. So I spent the summer as one of the medical directors for the bubble in Toronto for the play-in round and then the first couple of rounds. So I was in for 2 weeks, and then I was out for 2 weeks, and I went back in for a week. And so and obviously I grew up a Leafs fan. I'm a professional now, so I try not to be too fan. In fact, these were the rare times I'd actually take a photo while I was working. And so I was there responsible for, this is kind of cool, and I figure people want to ask me questions about it. I'd be happy to talk about this for hours. So I'll try and keep it cut down a bit. But I'll show you a couple of pictures and then cut out for a second. But and so this was that was sort of the internal feel of the place, and there was not any fans. It was very surreal. Real experience. It was an unbelievable experience. And someone asked me, "Would you do it again?" And I said, "Well, I would do it again in February." It was very hard you didn't realize how weird it was being in a bubble until you left that bubble. So I left the bubble and went up north with my family because they were on vacation. And as soon as you left the bubble and sort of drove outside of Toronto, you're like, man, that was a very weird experience. And so for those people, in goodness, they are paid very well to play a game. So I don't think any of us would feel bad for hockey players. But for those that progressed all the way to the finals and played and transferred over to Edmonton and played at Edmonton, they were in the bubble for almost 2 months. We're very close to 2 months. And even if you count the part before where they were in sort of a partial bubble, in the lead up to it, it was a mental strain for sure. And it's one of the few times that, I mean, I have respect for them for sure, but one of those times where I was like, yeah, this is really tough on them. And so unbelievable amount of work. The Leaf physician who I work very closely with in my roles was the overall director of the whole thing and did an unbelievable job to get all the way through with no positive COVID tests. And we were tested every day, and we stayed in the bubble of the hotel and just the hotel and the rink, and tried their best to give stuff for players and staff to do. It was a really cool experience, and amazing that they were able to pull it off. I don't think they'd have any appetite to do it again, unless they absolutely have to. But it was pretty cool to sit. And I watched in the first round. I watched 27 professional hockey games over a 2-week period, and so got to see some unbelievable players up close and sat in those seats right by the benches that there's no way any of us would ever sit in, right? Those are for the corporate folk who have their season tickets and things. And so pretty cool experience to be that close. And the other part of it, I always joke, the medicine of the job I do. So I'm the team physician for the Marlies, and then I help out with the Leafs as the critical side for the rink if something happens to either player on the ice. And the medical side of it is always super easy to handle, interesting, but easy and nice because it's private. But again, I end up being a fan of it, and sort of the interesting stuff is the interaction with the players and see where they see their thought process and see the sort of the strategy of the coaches and things. And so after that, we came back and had about a week or two, and then we started to hear the conversation of the second wave. And really, the second wave came from, I think, fairly easily matched up to going back to school and some of the challenges that came there. And so the initial challenges for us was really testing, and we've all heard this in the news. And so we cover the assessment center in King Street. By we, I mean the emergency physicians cover on the weekend, Saturday, Sunday. And so just having to go from seeing 80 to 90 people in a 4-hour shift between 10 and 2 was when we would cover it, to 350 to 400 people. And then we added from 9 to 3, we would see 400 people through the testing center. And how do you get people through? How do you get some turnaround back? How do you create an environment where we're there as physicians as much to pick out that one sick child who's actually had a fever for 4 days? And so the binary question of do you have COVID or do you not have COVID really isn't the important question. Is, are you sick? Are you not sick? And so trying to watch these people go through and capture them. And most people are actually very reasonable. It wasn't that people were anxious. It wasn't that people wanted to just see their in-laws or see their mom or dad or see their kids. It was that the indication, first of all, Premier Ford said anybody who wants a test will get a test. And so it was really reticent to back down on that because it was sort of his political line in the sand. But also it set up a lot of things where, you know, if the kids wanted to go back to school, they had to have a negative COVID. I'm sure everyone's experienced, if you want to see a loved one in long-term care, every 14 days, you have to have a negative COVID to go see them. If you want to go back to work, they want a COVID. So it was people who were appropriately jumping through the hoops. Some were sick, some wanted to make sure they didn't have COVID. Some had been exposed to someone who was COVID positive and had been through contact tracing told to go get tested themselves. And so it wasn't a lot of people who were just like, I just want to make sure I'm going to go see my girlfriend and I want to make it. That really wasn't the lived experience through it at all. And unfortunate that message came out there. It was the public being very reasonable and following the rules that were put in place. And so a big step happened when we started to adjust who needed them from school. So there's kids have one minor symptom, they don't have to get tested. If they have a major symptom, they do. If they have 2 minors, they do. And so it's amazing how much that cut back a little bit. And I suspect over the coming weeks, we're going to pivot from just screening and jumping through the hoops to actually people who are ill, who truly need to know that they don't have COVID. And so then they started to put in arbitrary breaks on it, like you have to have an appointment, you can't just show up and walk in, which then got all of the chiefs in the Hamilton area and across the province, but specifically and selfishly for us, anxious, because everything backs up to the emerge. So if you put in roadblocks to prevent somebody from going to get something done in the community, it just means that if they still really need it, they're going to come to emerge. And so fortunately, we haven't seen that yet. The testing centers have been able to sort of increase their turnaround times, they've increased their available appointments, and we haven't seen the influx into emerge yet of people who are more or less just looking for testing and couldn't get an appointment. How that will happen as things evolve, and will it evolve that way, is the other question, because the lived experience in the Southern Hemisphere through Australia was that all the social distancing and masking and washing and things have really flattened entirely, not only COVID to some extent, there were some hot spots at times, but essentially made their flu season next to nil, and all the really cough and colds that we see, the regular viruses, non-existent for them for their winter season. Now, someone made the point that, well, they have 15-degree weather, which is true, but actually, if you compare year over year, just in that region, 15-degree weather in both years, there was an incredibly precipitous drop in the infection rate. And so there is hope that maybe all of this we're doing to prevent COVID will actually also prevent all the usual coughs and colds we get. And so then we're into sort of what we've tried to do, and what we learned from the first one was all of these speculative graphs that everyone would see, the doomsday scenarios. It was, well, is that really do we need to respond to that, or should we have true objective metrics that will allow us to decide? And this brings in a bit of my role as planning chief for now. And so we have a table of 10 metrics that help determine if we need to cut down on ORs, do we need to cut back on ambulatory care visits? Because what we know is that, yes, we want to respond to COVID, and yes, we need to keep the public healthy, but part of keeping the public healthy is getting their ORs when they do ORs. And we know that study came out through CMATCH that we're 18 to 24 months behind some of these. It will take that long to get caught up in some of our surgeries. And so recognizing that as a hospital, we have a sort of a responsibility to the public to get those things done as well. It's not just all COVID all the time. And so trying to keep that going while recognizing that we're on this sort of challenge of, are we going to see increased volumes? The challenge we have right now is we're not at a 50 to 60% capacity in our hospital. We're at above 90% capacity, and in Ottawa they're over 100% capacity. And we haven't yet seen a similar decrease in our volume through ED that we did the last time. And I think too often people in medicine take a myopic view and say we need to just close everything down. And I more subscribe to we have to balance, what's that do to our economy? What's that do to putting people out of work? What's that do? There's a whole other aspect to this. And so if we look at it as people in medicine look at it and say we need to protect our healthcare resources, of course the answer is shut everything down, keep everybody home. But what's the impact on kids for not going to school and not having some outlets? What's the impact on the public who are at a 20-25% unemployment rate? And so as they try, and I think I understand where they're coming from, to keep the economy going, I don't think we'll see that similar decrease in volume in ED. And so then we're left with a hospital that's above 90% capacity, with ongoing emerge visits at near their usual volume, or about 90% of their volume, 80% of their volume. And then how do we do all this flow through stuff? And fortunately, we're just dusting off our books, and we've got them all there from all the work we did in the spring. But we have to be ready that we don't really know if those flow through things were the right flow through things, and probably pieces of it weren't, and we'll have to change, but they were never really stressed to know if they were right or wrong. And so that's our challenge now, is waiting to see what happens. We have started to see a bit of a drop in volume, and I think there is a direct, I'm not seeing a graph on it, but there seems a direct correlation to the heightened words from either Dr. Williams or Premier Ford or Minister Elliott, as they start to heighten their concerns, and it gets out in the public about various other concerns in communities, it does lead to a bit of a drop. And so we might be seeing a little bit of that happening now. And so the other piece that we did here, and this is our innovative stuff that as we look to what else can we do, is virtual. And so we talked earlier on about all the various platforms we have. And so we looked at 2 virtual options that we think will be impactful as we go through the second wave here. And so the first one is the LTC Cares, which stands for Consult and Recommendation for Emergency Support Services. Essentially, each long-term care home has a physician, a family physician, who provides oversight, and people who provide call on the evening. And so what we've created through HHS and ourselves is a system wherein that physician can say, well, let me call the emerge and see if we can do something to prevent that individual from having to come to emerge. And so we put in place things like getting x-rays done in expedited fashion in the community, direct referrals to fracture clinic. If they get that x-ray and show a fracture that doesn't involve needing to come for surgery, getting splints out to the home so that we can actually provide the care to them there without them having to come into the hospital. One, that because it's safer for them with transport and coming here, particularly if they're in a home that's not an outbreak. And two, it just frees up beds for us to allow flow through and keep physical distancing for people. And this can be done on a virtual visit if we need to see the patient, to see how they're doing. In COVID terms or COVID times, certainly the disease progression would suggest that they'll get more short of breath. We can look at them together and say, are they so short of breath that they need to come to the hospital? Can we do some things to mitigate them needing to come? And maybe we'll be successful, maybe we'll not. And it really isn't a barrier to coming to emerge, and we don't view it as that, because I think that's unfair to the patient. It's more a matter, can we facilitate their care without them having to come in? So it's actually been a fairly successful program. I think we've managed to keep, I think we've had 90 in sort of the 5 or 6 months we've had 90 visits or 80 visits, and about a third to half we've been able to actually avoid them having to come to hospital. So it's a significant, we're looking at sort of 40 to 50 patients who we've managed to provide safe and appropriate care to them, while still keeping them out of the department and keeping them out of the hospital, which is a win for all involved. The last project we have going is, and this is just at St. Joe's right now, is actually developing a virtual care model for potential patients to actually engage with us just like this as an interaction. And so they're doing it at CHEO in Ottawa and have had good success. And only in their department. They did it briefly in Kitchener-Waterloo, and that's kind of where we first heard about it. And so at St. Joe's, we have Epic, which is our computer system, which makes it really easy to do these virtual visits. And so we developed this late July, early August. And so slow uptake so far because it wasn't necessary, but I think will be a really useful resource moving forward. And so essentially it's for anybody over the age of 18. Right now we're doing between 10 and 6. 10-minute appointments where someone can go to the website, and it's at the bottom there, click on it, put in some demographics, and say that you want an appointment. That appointment then gets pushed to our registration clerk, who responds back within the hour to say, here's your appointment. And then as a physician at home, we get a list of people who want a virtual visit. We click on the next appointment, start a Zoom call with them, and they can be sitting in the comfort of their home and interact with me, and we can decide whether they need to come in. And certainly there will be presentations that require us to bring them into hospital. And again, I as I've talked to the press about it and talked to other people about it, it's not a failure if you come to hospital, but if we can manage your care without you having to come, without worrying about physical distancing in the waiting room, if you have potential COVID, or you have COVID and have other concerns, or you have COVID and you're worried you're getting sicker, we can see you from home without you having to break your isolation and care for you and not feel like you're lost. And so the last one I had, which was amazing, was a woman whose partner was positive. She thought she was positive. She'd already been to the assessment center. I was able to look up on our computer on Clinical Connect, find out that she was in fact positive and she was pregnant. And so we had a great conversation about what to do, what to worry about, what medications she could use, and could answer all that without her ever having to leave her home. Had the added benefit of my wife's actually an obstetrician, so it was quite funny, because she asked a question and I was like, hang on one second. And I ducked out of the room and talked to my wife and ducked back in. And I said, oh, my wife's an obstetrician. And actually, here's the answer to that question. And so that obviously was a piece that you're not going to get every time, but it was a piece where there was someone who was COVID positive who otherwise would have potentially gone either to her family doctor, which actually couldn't, because family doctors are not seeing them if they have COVID, but would have come to emerge, would have sat in a waiting room, would have had appropriate questions and trying to do the right thing. She wasn't doing it to make people ill, but would have risked getting people ill. And so it was like the hallmark case of why we do it. And we've seen others, concussions and various rashes, and we're able to sort of provide care without them. We always say family doc first, but if you can't get into your family doctor, or you have a family doctor, it's another resource that they can use. And just again, to try and, if we can offset, and our numbers, while low initially in the number of people we're seeing, we're only having to have about 10% of the patient population come to emerge. And so if we can offload those 90%, particularly as that volume gets bigger, that's people who we don't have to worry about navigating through the department and either not expose them to COVID, or if they potentially have COVID, expose them to everybody else. And so it's one of those things that we've pushed forward aggressively, that in non-COVID time would have taken months and meetings and bureaucratic red tape, and it got pushed through in about an 8-week time. We were able to create the whole process. And so one of those rare times that that we could see COVID allow us to push things forward. And so that's a little bit of what people actually need. And so the big point from this slide is that we recognize there's an access problem here, right? There's an access problem for people who live on the streets, or who have mental health or issues or substance issues, who are living in shelters. It's an access problem potentially for elderly individuals, but that perhaps their family can support them, and we certainly allow the family to support them to sort of set up the appointment. The other advantage is with visitor restrictions, the caregiver can be with their family member on the call, provided they give consent, of course, to engage and actually hear the conversation, which is one of the great failings isn't the right word, because it makes sense why we're keeping visitors away, but it's one of those things that I really hate telling visitors when they come in, and family members when they come in, that yes, your loved one is ill, and yes, you're worried about them, and maybe they don't speak English as well, or maybe they're a little bit confused, and you really want to impart some information to them, and then we're saying just sit in the waiting room or sit in your car. And so I get that is a huge problem, and so it's another piece that can be solved through here. But so we're working with our local shelter health networks. We're working with with Good Shepherd, with other people, to try and figure out a way for access for those individuals, particularly people who have mental health or who have substance issues, sometimes feel marginalized and emerge. So it may actually be a program where they could feel like, I can get my care, I can ask my questions without being judged. And it's unfortunate they feel that way, but I think it's through lived experience. I don't think they're wrong. I think they do at times get judged, unfortunately, for their illness. And so I could see this as an opportunity. So our hope and our goal is that this is a program that was born out of the pandemic and has useful pandemic viability, but to actually post on the other half of this, the other side of this, whenever that is and whatever that looks like, that this isn't really just a pilot, but this would be a program that we could carry forward.
So the first question, the challenges of communication in the COVID pandemic include not only the problem of misinformation on social media, but also disagreement within the scientific community. Example, the recent Great Barrington Declaration. How should people deal with this kind of issue?
Yeah, that's a great question, right? It's a weird time because we've never before had access to so much information, but how do we parse out what is true and what isn't true? And I think from our perspective, I think that's where we need to be leaders a bit more and get out here. And that's why I tried to add, even just briefly here, some people that you can follow that will give you information. Now, that information, the challenge there is there are people in the medical community themselves who will say masking isn't appropriate and masking isn't protecting you, and that this isn't airborne, this is more droplet. And I think, generally speaking, I think the communication coming out of the province has been difficult. I think some of the communication coming from Ms. Tam has been better, in that she will pivot and wait for the evidence to say, okay, yes, we now have lots of evidence that this is progressing this way. So it isn't a failure to change their mind at times if they're using all the available information. The background noise is a tough one, and I would say, as a general rule, be saying social media. I think social media isn't necessarily the best place to get it. My experience with the CBC and the CTV and experts that they get on there, both ID physicians and otherwise, are actually pretty spot on about the concerns and recognizing some of the limitations for the public. But I've actually found that to be the face validity of that to be very good.
What are the current rates of infection in Hamilton hospitals? And is it safe to go to a hospital for a checkup? And in this particular one, they're suggesting a pacemaker checkup.
Sure. Yeah, I think that's, if we get anything out of this talk, I would like that to be the message, that it's extraordinarily safe. We have an extraordinarily low rate of COVID right now. I think we have 2 in the hospital. I think HHS may have 2 or 3. I have a meeting this afternoon to get the updated numbers, but exceedingly low amount of COVID in the hospital. I think in part because our community rate of infection right now is mostly in the younger population. and they aren't being hospitalized or needing to come to the hospital. So we're seeing a lot of positives come through our assessment center of young, healthy individuals who are getting it, but we're not seeing a lot come through emerge or are admitted with it. And so extraordinarily safe. The precautions in place in the hospital now to allow you to get to your outpatient visit are extraordinarily safe. And this is exactly the things that we want that message for, so that these general health things like a pacemaker, obviously integral to your health, that we keep going along and getting those checked up, because COVID is relatively low right now, and we'd hate for something else to happen on a relatively low risk thing.
Okay. Is the technology utilized in point of care rapid testing as accurate, sensitive, and reliable as PCR done in the medical lab?
That's a great question. I could talk about this one for hours, but no, it is not. It is still useful, and that's sort of, again, in the public. If people remember, initially they didn't. The Health Canada didn't actually okay those rapid testing, and then they did a flip flop a few days later and gave them their approval. And we talked about this is there utility in emerge? And we said, well, again, getting back to AGMPs, could I do a rapid test, realize they're not positive, and then do some other testing? But if we look at true numbers, the PCR is still about 90 to 95% effective at picking up. So we do see some false negatives. Whereas the point of care technology is probably an element of 10 to 15% lower than that. And so it isn't as good in a low. So then you get into a prevalence discussion about, okay, when could you use it? And so it's used in a low risk environment to rule it out. So it's not, if it's too high risk an environment with that low sensitivity, it wouldn't be an effective test to rule it out. But if you could use it in a relatively low risk situation, or to determine whether there's an outbreak at a home, that sort of thing, there'd be some utility for it. But for the average person, if you're low risk and you want to do a point of care test, it will still give you that element of security, but it's not foolproof.
Okay. The next one does talk about the 14-day restriction. Do you think that the 14 days is an accurate number?
Yeah, so we've just shifted a bit, and it seems a bit, and I was saying to someone else, it seems a bit weird, but so if you're ill with it, if you're test positive for COVID, what we know is that you're probably only infectious for 10 days. So they actually can return to work on day 11. But if you're exposed to someone, or you've traveled, the travel one I'm going to disregard because I think that one's silly, but if you've been exposed to a COVID positive and you yourself are not symptomatic and test negative, and you have to quarantine for those 14 days, even though if you actually had it, your isolation would be 11. If you don't have it, it is 14, because it will shed, or you will convert to a symptomatic up to 14 days. And so even though it seems excessive and you've been healthy for those entire 14 days, there is evidence that you could convert to a symptomatic someone. And so there's that whole piece of asymptomatic or mildly symptomatic, and then you don't quarantine and you spread it. There's also the thing where you could be asymptomatic up to day 12, you're out doing something at day 12, and then you become symptomatic day 13, 14. And so the evidence would suggest that yes, you still could be positive up to 14, but in an odd sort of reversal, if you have it, you're actually probably only symptomatic, you're only infectious till day 11.
Okay. This question's about your St. Joe's Virtual Care Emergency Program. Is there a specified catchment area for this?
There isn't, and in fact, the government has just announced some funding that's available to this for virtual care through the ED. And so with that, we're hoping to expand it even further, but there is no requirement to put a postal code and say, oh, you're from Burlington, and therefore you can't access this. It might mean that you don't, like, if we get to the point where we say you probably need to come into hospital to be seen in the emerge, that can happen at Joe Brandt. It doesn't have to happen at St. Joe's. And so it's really just engaging to see. And I said in a couple of my media hits, the number one question I get is, from friends and family, is, do I need to go to emerge with this? And so I think this just gives the public that opportunity to ask that question to someone if you don't have a physician in the family. And so there is no catchment blocking at all for it.
Okay. How do you treat patients who are isolated in homes with an abuser and unable to communicate with outsiders? The rates of domestic violence are steadily increasing because of COVID. Are emergency department personnel able to recognize signs, symptoms of abuse and violence?
Yeah, a great question. Horrible reality. Um, we as ED physicians, I think, if I'm being truthful, sometimes, not sometimes, but we can be poor at recognizing those that the obvious ones with certain injuries, certain breaks of the bone that just happen in a way that doesn't make sense to the how they're saying it happened. Those are easier, but some of the emotional impact, some of the other things is sometimes harder to see. And so what we've done to offset that is we have far more social work presence in our emerges, far more OT, PT who are engaging with people to try and sort of pick those people up, doing assessment, mostly making nurses and physicians aware that we should always be aware of this. But in our current climate, we know, and we've all seen the studies to say that the rate of these abuses and violence and things are going up. And so if we have a point in time with someone, be understanding too, there may be not a physical evidence, but if they seem a little off, and if you do the job long enough, you can see the interaction with someone just isn't quite right. And so be aware of that and trigger it and say, is everything okay at home? And so I've asked that question far more in the last 6 months than I ever did before, because we know it's a problem.
Someone's looking for the website for their virtual care. Do you have that off the top of your head, or we can provide that
It's
after
in
the
the
fact?
it's in the bottom page of the slide,
Okay.
on one of my slides, so it'll be in the thing. But essentially, it's www.stjoes.ca // emergency virtual visits with an S.
So
And if I can
those-
put a little plug in there, our volume, we have much more capacity to see people than we're seeing. And so spread the word to your families, spread the word to everybody that it's service we believe in and happy to provide. And there is slack in the system to support people connecting with it.
Someone's been wearing their blue and white masks repeatedly before changing them. And I'm sure they're not the only one of us. Is it okay to reuse these? And if we're healthy and just wear them to protect ourselves and others?
Yes, I would say so. When you take it off, make sure you wash your hands immediately afterwards. You can repeat them. Just avoid the big thing to avoid is touching the outside of the mask. So if you can grab it by the ear loops and pull it off, and if you have somewhere you hang it. Some people will do, if you have several of them, they know that after 2 or 3 days, you can be quite certain that there's no further virus on it. So some people will have 2 or 3 of them and just cycle through daily and say, I'll use this one for a day, and then you kind of rotate through. You can reuse them for sure. Some of those cloth masks you can wash. The evidence would say the cloth masks are as effective. Just the big thing is don't touch the front when you're taking it off. Or if you do touch the front, make sure you wash your hands. You should wash your hands immediately after taking off the mask either way, but particularly if you've touched the front of it.
Okay. Is it safe to visit a hotspot like Toronto, Peel, Ottawa?
Yeah, I think it depends on was entailed in your visit. So I wouldn't necessarily go and sit in restaurants are closed right now in that area, but I wouldn't necessarily sit inside a place that doesn't have adequate physical distancing. So if you're going somewhere, I would ask questions about what they're doing to prevent infection, what's their infection control rate, or either ask or when you arrive, look and see what it is. I would absolutely be masking if I went there and washing my hands and doing all those things. And so is it safe to go there? Yes, I would say your risk is greater than here, but if you're doing it in a safe way and in an appropriate environment, I don't think you have to avoid the place entirely.
Last question. From your experience in the hospital and the NHL bubble, what have you learned about managing the psychological impacts of the pandemic?
I think the two things I've learned for sure is that it's very real. And so the Zoom fatigue, the fatigue of not being able to interact and socialize, and I think I'm sure your audience has done the same, and tried to have Zoom meetings with people or Zoom bridge or Zoom card games or whatever that all of us have done. It isn't the same, and that just that ability to interact with people, to touch people, to give somebody a hug, all those things that we took for granted forever, is absolutely there. And so I think the first step is to recognize it, to talk to people about it as a healthcare provider, to say, that's hard, this is hard. Like, are you doing okay? Beyond just what's your problem? How can we help today? Like, recognize that there's more going on and that some people's physical presentations for illness is actually more driven by psychological things. Not to say that we just immediately think it's in your head, but ask the question. And the other part is recognizing the value of any kind of interaction, any kind of exercise. And so one of the things we found with the bubble was that they allowed us to go to BMO Field and to run around and to play Frisbee and to do those sort of things. And how much better you felt on a day so when I was there, the first few week was 3 games. So we'd start at 11 o'clock in the morning and we'd be done at 12 o'clock at night. And so if I had meetings in the morning, I wouldn't exercise. And the difference in your outlook when you spend all day meetings, watching a hockey game isn't hard. I didn't have to do a lot. I'm not suggesting it was me, but you were on call. You were there for work and not necessarily for yourself. And so finding that outlet and what a difference it made for everybody. And so little walks, just getting outside, doing something beyond just being on social media or being on TV. And so that's it. And I used to, not that I disregarded it, but as an emerge doc, I'm more in tune to say, how's it going for you? Like, this is tough for you to see a mom come in and you say, how you doing? Are you okay? One of the things I'm thankful for in a way is my kids are 11 and 14. And I think, my goodness, people who have 2 and 4 and 5-year-olds, how do they get through a day when they were in quarantine where they couldn't, that's hard for them. And so just recognizing and talking to people about it.
Mm-hmm.